So you are now live.
Thank you. Good afternoon and welcome everybody to the Council of Governors meeting. Very pleased to report that we're in position today to live stream the meeting in the interest of making sure our meetings are accessible and indeed our decision making transparent in the reality that is COVID. I would ask that everybody who's not speaking at the moment goes on mute, please, as that can improve the sound quality. And I have a number of announcements, very sadly, to let you know that Janet Shaw, Norman's wife, passed away at the weekend after a period of illness, and both Denise and I have expressed the condolences of the council to the family at this sad time. It's also, we've had, Denise and I have had a letter of resignation from Angela Parnell. Angela's husband has been unwell for some time and Angela would like to have the opportunity to prioritise her family at this time, which obviously we understand. But given the distinguished nature of Angela's service to the council, we really do look forward to an opportunity at a later date to bring her back and to thank her for everything she's done. And whilst we're on the announcements, equally importantly, to bring to your attention that this is the final meeting for Lynn Andrews, our Director of Nursing. Lynn has been a fabulous colleague and she's revolutionised the approach to quality governance and patient experience in the Trust. She will be leaving us having brought us to the top performing benchmark of any trust in the country for our inpatient experience. Lovely position to be in, and has laid the foundations, of course, taking us from requires improvement through to good, and indeed maintaining our good rating in our recent CQC inspection. And as I've said to Lynn privately, and I report here, I have every trust and confidence that we will reach our ambition to be CQC outstanding. And whoever is sitting in Lynn's chair at that point in time will have nobody to thank really other than Lynn for the fabulous job she's done in making sustainable change that I feel sure is going to come good for us in the not too distant future. So Lynn, you go with our very best regards, our huge gratitude and appreciation. And again, we don't intend letting you get too far without the opportunity for a, you know, an in-person celebration of all that you've achieved during your time at the Trust. So we look forward to that at a future date. That brings us on to the note of the apologies, if we may please. Are there any apologies, Nicola?
I've just got apologies from Keith Nurcombe, Mick Portman, Norman Shaw, John Bolt and Angela Parnell.
Very good. We have at this juncture in board meetings been reflecting on lives lost due to COVID, and also reflecting on the phenomenal efforts of our staff during this time to look after patients, both COVID and non-COVID, so very well, and indeed to reflect on the success we've had in the volumes of patients who've been discharged home medically fit and well, and indeed to thank the community for the fabulous job that they have done in supporting us. I think it would be fair to say that we wouldn't have been able to rise to the challenge in the way we have had it not been for the magnificent support we've had from right across the community. Everything from pizzas to meals to hand knitted protectors for ears for those who are constantly wearing masks, to crocheted hearts to keep couples in touch who, you know, have to forego visiting. Everything we could have wished for, and the community have come forward and offered up very willingly, and not just in the early weeks of this pandemic, right through. So we're very grateful for that. But also in this meeting, you know that there's an opportunity for us to have quite a detailed briefing, not only on COVID, but on restoration and recovery. So more of that a bit later on in the meeting. So if I can just move to item 2, please, and ask if there are any declarations of interest with respect to this agenda. Obviously, we'll note the register of interest with regard to any other declarations. I would be grateful if you could indicate in the chat box if there's anybody who needs to bring a declaration to our attention, please. I'll take that silence as saying no, so thank you for that. Now, at this point in the meeting, when we have members of the public in the room, we normally go to them and say, are there any questions you'd like to ask? I'm not quite sure, for reasons you'll understand, how many members of the public we might have on this call, but all of you are very welcome. And I'm very happy to take any questions you might have. Gillian advises me that we've had none so far. But what I would like to invite you to do is, if you do have a question at any point during the meeting, please do post it. There's a box where you can go in and post a question. I'm not going to take it during the meeting because the Council of Governors is a meeting in public rather than a public meeting. But I will return at the end of the agenda as we conclude today's discussions to reflect on any questions that have been raised, and of course to answer them or give any further clarification or insights we might be able to share on issues you want to raise that haven't been covered in the meeting. So that's an open invitation. So on that note, I'll move us on, if I may, to agenda item 4, which is the Chief Exec's briefing. Over to you, please, Angie.
Thanks, Helen. And no surprise again this month that my briefing is COVID focused. But I did just want to note, as Helen has reflected, the good CQC rating that we've obviously had that formal announcement since we last met as a council. So to pass on my thanks to all our staff for maintaining a good rating, no mean feat, in particular in terms of the challenges we've faced over the last year. There are areas that we need to work on, and we'll be obviously working hard to do that and progress going forwards. In terms of COVID, just to reflect, as Helen has said, on the sad cases of those families and members of our community that we have lost to COVID. 128 inpatients have sadly passed away with us since March. More positively, our numbers of COVID inpatients are reducing, and in line with the national work, we are concentrating more and more on how we build our services back up again. Our emergency services have continued throughout the pandemic. It's our elective services and our outpatients that, again, have continued in different ways, and we're looking at how we can maintain some of the lessons learned, but continue to build up that activity to what's needed for our patients. I'm going to hand over to Lynn to take you through a bit more of the detail. As you'll know, when we last spoke, the world of COVID changes by not only the day but by the hour, and we try to continue to work as well as we can to support our own staff and our own local population, while still working in a national level for incidents. So it raises some challenges, but as ever, Lynn and the team have responded magnificently to that. So I'll get Lynn to take you through the update, and then Tony's going to later on talk a little bit more around recovery and restoration plans, around how we're getting things back to as normal as we can. So over to you, Lynn. Thank you.
Thank you very much, and Helen, I dropped a comment into the comments, but thank you also for your thanks earlier on as well. Obviously, there are a number of areas that we are interested in when we talk about COVID, not least the point Angie's made about the reducing numbers we have in the organisation. And I'm pleased to say that today we're in single figures of positive cases within the town, and that in itself is a really good place to be. You know, so that just shows you the level of activity we've gone from as well, which we previously reported, down to that situation. That leads to the ability for us to de-escalate out of areas that we have used for COVID, and there have been plans in place that we've made to do that. We've come out of one ward, and we're now coming out of the second ward, and as I say, there are a few patients in the organisation, and predominantly these now are in our specialist wards where they need that specialist care as opposed to a respiratory positive case. It's more about their clinical need that is leading to the priority of their care. We obviously now are in a position where we also swab all patients that are admitted, and that is the movement that happened about 3 or 4 weeks ago now. That includes maternity cases, paediatrics and adult care, and any patients that are a day case that then come in to stay for overnight, we will swab as well. I am actually very pleased to be able to report, and this is also a significant statistic because it relates to the sort of level of prevalence of COVID, that with all the swabs that we've undertaken to date, there's a 2% positive in that sample, which is actually very low. And so that is reassuring for us too, that we're able to see why what the national and team and the government briefs talk about the R number. We can see in Chesterfield and Chesterfield patients come in from our surroundings that level is low. We are keen to know that we have got the appropriate PPE in, and that's something I monitor every single day. We do a daily return back to the Midlands region, which shows me what the position is with PPE. I know I've got at all times what minimum numbers we've got, and I can see that at the minute we've got a minimum number of 3 days and more for everything, so that's also very reassuring. We're still waiting for some further guidance on the wearing of face coverings and masks in the organisation, but we're planning ahead with regards to that to know what we're going to put in place and the stocks that we have so we can accommodate for that moving forward into next week. We've also been testing for antibody tests, which is came online nearly a couple of weeks ago now, and again that opportunity for all of our staff to go forward for that, and we're making fantastic inroads. We've nearly got 50%, just over 50% of our staff who've booked to have that antibody test done, and the results are going to start coming out to them very shortly. So the testing side of things nationally, as you will have seen, is ramping up, and before long we'll have an understanding nationally about, again, where there may be pockets of that staff showing that they have been antibody tested and what the position is, as well as what we've got with our patient position. And there's further research going to happen as well, which we are going to enter into if our application is accepted, to really build a good picture about COVID moving forward. The health and wellbeing support that we give our staff as well, maybe Zoe wants to comment on that, but despite the fact we've got low patient numbers of positive COVID cases and we're moving out of our wards where there's been the more critically ill, the seriously ill and patients who have died, we can't forget that the impact that that's had on our staff is not just about now, it may be lasting for further longer in the post-COVID situation. So the support we have in for our staff is quite extensive, both at a local level and national. We've had lovely support about us, and I want to just mention Ashgate in particular because they've been coming in to do debriefing sessions with our staff, been particularly helpful, and I know looking forward it might be something we consider through our charitable funds and how we support through that. Which is so I think they are the main things that I just wanted to cover. I'm happy to take any questions beyond that. But and as I said, you mentioned it, Angie, that Tony will pick up our recovery and restoration elements as well later on in the agenda. But they were the main things, and happy to take questions at your whichever way you want to deal with that, Helen.
Thank you very much, Lynn. I'm going to go to Zoe next to just talk about the support we've been putting in place for staff. And then I'm going to, somewhat out of order on the agenda, I'm going to take the issues that have come up in the Governor's pre-meeting because they were all virtually exclusively related to COVID. So if I summarise those, in fact, I'm going to summarise those now. That'll give you a chance to have a think about them, Lynn. And then we'll go to Zoe for the update. So there was a lot about, and so you're aware too, Zoe, a lot about what support we're giving to staff, particularly around mental health support. There was a question of what role chaplaincy is playing in that in terms of spiritual support being an important part of the kind of preventative package, and not least of all seeking some assurance that the decision that was taken at the last board meeting to invest in chaplaincy has actually happened. Then there was a question around the follow-up that's available for COVID patients, and it was in 2 dimensions. The first dimension was when people are let out of ITU, whatever the circumstances, good practice is that there is good follow-up. So the first question is our follow-up in normal circumstances for those patients, perhaps, for example, on a par with a follow-up we know that is highly regarded in Sherwood, where you don't only get follow-up from the ITU team, but from the MDT team that was involved in your care. And apparently there's a very good little BBC Twitter piece describing exactly how it's practiced there. So there was a question about how in normal circumstances would our follow-up offer a benchmark against good practice, and particularly in a COVID context, are we managing to have the resource to follow up not only with folk that come out of ITU, but perhaps people who are coming more widely out of the hospital but have particular needs given COVID. And then the second question, and this came from Ruth for reasons you will understand, is with respect to ongoing health needs, classic examples being respiratory or anticoagulation treatments that may be required. Is the hospital putting in place good processes and procedures so that we're all playing our full and respective roles rather than bouncing patients between the hospital and their GP, and that's all being handled in the best possible way? And the other question that relates to all this was a reflection that we've had 30% mortality with respect to COVID patients, which seems to track the national average. But on the basis of having had much experience now, particularly of treating acute patients in ITU, for example, who need ventilation and the like, have we learned and been able to kind of learn in real time in terms of us perhaps being able to see that mortality rate fall in the fullness of time? So I'm going. There were two other questions that arose in the pre-session, but they're the ones that relate to COVID. So have a think, Lynn, and on that note, if I can come to you, please, Zoe.
Thank you, Helen. So Lynn touched a little on the health and wellbeing offer that we've had in place, which we have enhanced during the COVID response and will continue to keep in place. Since quite early on in the emergency response, we've been working with our system partners, so across Joined Up Care Derbyshire, to help with that in terms of sharing resources also, and particularly around the mental health support and the psychological support. The model's been built to recognise that different people need different things at different times, and there are different stages around how people feel psychologically in situations such as this. So some people need the more immediate response, and Lynn talked about the support we've been getting from Ashgate Hospice, which has been particularly for areas who are working with COVID patients, so the wards and critical care, for example, in terms of debriefing, and that has, as Lynn said, that's been really, really valuable, and the teams there have really appreciated that. Equally, some people may want a longer term, or it might be at a later stage where they feel that they need that kind of support. So, for example, enhanced counselling's in place, and we've got access to other partners' resources also. So it's very much a shared system approach. We've updated our website, so everything that we have available is on there. Moving away from sort of mental health, thinking about other things as well. We've thought about sort of financial support for people and how people can be helped to be signposted to places around that. Some of the physical side of things, so the back to work schemes, some of the online classes we've introduced, so like yoga and Pilates, which previously would have been in a room, looking to do things like that in a different way. So recognising health and wellbeing is holistic. At a national level, they've really introduced a really comprehensive support package, I think, quite quickly. And I know they've worked nationally with the military, for example, to understand things like the long-term effect of sort of psychological situations. So there's a website in place, there's a number of apps in place nationally as well as locally, and there's also a helpline which is supported by sort of trained listeners and trained counsellors. So there is quite a comprehensive package of support in place for people. In terms of other support we've made available, at the start of May, Angie and I wrote out to all our staff members, really to describe what support was out there for them and highlighting where they could find that information. As part of that in particular, we strengthened our approach to supporting our people who might be more vulnerable groups. So, for example, BAME colleagues, there's a sort of a growing evidence around the disproportionate impact of COVID on people from BAME communities. So we, for example, made vitamin D tablets, over-the-counter tablets available from the pharmacy here, free of charge for those colleagues. Other examples would be people with a disability or underlying health condition, for example. So the approach we've put in place is around individual risk-based conversations, which people are having with their managers to understand how they are feeling and what support they need, and any further steps that we may need to take at this time to continue to support them. And they're happening now across the organisation, using a very sort of structured approach, and we're gathering themes and sort of feedback through that as well. So if there's anything that needs to translate to a more trust-wide level as an issue, then that's something that we can address also. Also in May, we gave the opportunity to hold listening sessions with senior leaders, which was opened out to all our people, and we particularly encouraged people from sort of diverse backgrounds. We did this with the support of our Be Yourself group, which the council will be familiar with, and sort of encouraged people to come forward, and people did, and they talked to. So I was one of the people, and I know other exec colleagues and other senior leaders did that also. And again, we've sort of collated the feedback we've had around that for future learning, and we've just been talking this week about maybe, well, we will offer that opportunity out again to people. So I think that really showed we value and want to sort of hear what people have to say and how we can keep supporting them. I'll touch on chaplaincy. Lynn will probably want to say more, I think. Certainly from the services that are being provided from the chaplaincy and spiritual support team at the moment, clearly they need to think about how they can do things in different ways. So I know, for example, they've been offering online services. I know Martin did at Easter and at other times as well. And there's been information about other, like Ramadan, for example. But I'm sure Lynn wants to say more about chaplaincy.
Thank you very much, Zoe. We pass back to you, please, Lynn.
Yes, thank you. So with regards to the questions, I'll just run through the answers to the questions as you've put them. So with just adding to Zoe's point, you might recall I mentioned that Sarah Ward had been working with Martin from a chaplaincy perspective to draw up a support package for our patients. And they've been taking that forward. We've obviously had additional chaplains come in as well, and the volunteer chaplains have come back in, some of those too. So that's built the team up, and there is an on-site presence. Martin obviously also comes in with colleagues at different times to support where requested, as well as proactively going around the wards and talking with patients and staff to give them that support. From a pastoral perspective, it's not necessarily about specific religion, so I think that's been really helpful. Ongoing post-discharge, whether that be from critical care or from the hospital, they also follow that through where they felt that that's been what the family or the relative and the patient have wanted. So I think it's been on a personal basis level as opposed to every single patient, and they've taken the feel from that as they've gone through it. So I think that's been a really helpful position. We have looked at, Martin has got some wonderful connections within his field, and there's one particular connection he's got at the minute that he's following up with regards to the funding element and the support that you mentioned, Helen, that we'd had a conversation about at board. It hasn't concluded yet, but we've certainly taken and followed that through, and I think that will be very helpful with regards to the work that can be going on through the chaplaincy route moving forward. With regards to critical care specifically and the lessons, I have seen some work that our teams in critical care have presented in a paper, and I've got that in front of me actually as it happens, and I don't know whether Hal's still with us or not, but we obviously have a lower percentage, a lower volume of patients that we cared for than nationally when you look at that in terms of the size of the organisation. But of the 47% patients that we had looked after at this point in time, 68% of our patients versus the national figure of 56% were discharged. So that's really good that we've been able to do that. And they believe the reasons we've done that is because a lower proportion of them were intubated and they were CPAP use. So I think it was the methodology of how to approach them, how we had early identification, movement into critical care, and the use of the modality for them that really helped. So that learning has come through already and that we're taking on. I mean, there's been other learning as well around pressure care within the area too, and how we prone patients. So I think there's something that we can take forward from that perspective as well. And so there's really positive results for all the hard work that the team have done in there. You know, we follow patients up after they've been discharged from critical care through the team that follow them through. And that has been an ongoing continued process that we have done. I think there's still more work that we can do though within the community to support how we actually make sure as a system we're following these patients all up appropriately, whether that be from a clinical condition or whether it be from a mental health or psychological position. And I think that's still work that we're all working through in the system. Although I know in terms of end of life, there's really good support there, governors, but I think there's still more work we can do from our patients on a basis. I haven't got anything to benchmark that against, so when you talk about other hospitals, Helen, I look at that, but we don't have data to demonstrate what that position is. But I do know that our consultants and clinicians are following patients up, and we're doing some very good telephone triage with those patients as well from an outpatient perspective too, and they're taking some of that on board to do for the discharges. Unfortunately, I personally can't comment on the question about anticoagulation or the relationship to that. It's not something I have to hand. Maybe something Hal is available and is online he can talk about. But at the minute, it's not something I have the information for. I can come back to you about that. But I think that summarises some of the answers to the questions that you've raised. Unless there's anything else that I've missed that anybody wants to talk about.
Thank you very much, Lynn. I think it will revert to Ruth on the anticoagulation point, but I think it wasn't only about the specific, I think it was about the generality of how the hospital worked with GPs in the discharge context. So we'll follow that up. Frank would like to come in. Frank.
Yes, it's really a question for Zoe. Just like to compliment on a comprehensive range of initiatives to support staff during this difficult period. But have we got any feedback on the number of staff that asked for support on the initiatives introduced?
Hi Frank, thank you. We have a regular workforce group who have been a bit of a task force alongside the operations group, the tactical group, etc. And until next week, we've been meeting daily, and we are keeping an eye on the number of conversations that are taking place, and we will be starting to gather the themes that are coming through from those. So I have not seen the meetings happened while I've been with you, so I don't know the latest position on that, but it is something that we are regularly looking at, and obviously that will continue to grow as well. We did have, I asked Martin a few weeks ago, the vitamin D tablets, number of colleagues taking up that offer, and I can find out the answer to that specifically. I can't remember the answer now, but some people were certainly taking that up. I can find out then.
Thanks, Zoe.
Thank you. Now I'm going to come to Glenys shortly, or to Glenys's question shortly, but just before I do, as it's related to COVID, but not directly related to COVID, I just see that Hal is offering to add a little to Lynn's report. Hal.
It was just to add to Lynn's report, really, that to reiterate the very good performance from the point of view of outcomes on intensive care compared to nationally in our hospital, which is a point of encouragement, but also to reflect that as well as the excellent care that they're giving there, a lot of that was related to the proactive decision making, both in the hospital and with local GPs, so working within the system regarding advanced decision making, so that there was a lot of work both in the hospital but across the system to ensure that the right decisions were made in advance of it becoming an immediate emergency where people were pushed into the corner and the wrong things were done. So that's something that's actually been really good across the Derbyshire system during this period, that communication between general practice and the hospital, sort of in advance of problems, if that makes sense. And the other thing was just to reassure people that the team that looks after patients after intensive care are already doing an outreach into the community, so they're picking up the patients after they've left hospital as well. And as Lynn says, that's a work in progress, but it is already happening out in the community post discharge from hospital as well as after discharge from intensive care.
Thank you very much, Hal. Helpful additions. I think on the point you raised about the quality of decision making, focused on each patient and in partnership between the hospital and the GP, it's a very good point, and our congratulations to all the clinicians involved. I'd also like to acknowledge the role Jane Stringfellow has played as chair of the Quality Committee and other members of that committee who were very quick to make sure that we had the appropriate assurance around clinical decision making in a COVID context. So our thanks to Jane and her colleagues on the committee. Glenys raises a very important point. So because of the COVID restrictions, visiting is curtailed, and a number of her constituents have asked her to raise the point about when we can expect to see visiting getting back to normal, not least of all as it's putting some people off coming for non-urgent operations, but of course things become more urgent if they get put off because of their concerns about having to forgo that support they normally have through visitors. So I don't know, Lynn, do you want to take that?
Yes, thank you. I mean, the first thing I would say is to please encourage people who require procedures to be done to come in. And our priority is to keep patients safe, which is why we've made the decision also about visiting. At the minute, we are still have positive cases in the trust, but we also know that we have a position where there is COVID with asymptomatic people, and that public and their staff, that we don't yet know what the prevalence of that is. And part of the antibody testing and the research is to determine that. That's one thing that we need a bit more understanding, particularly at the minute as well, where the government hasn't yet produced its guidance on face coverings or surgical masks or wearing in non-clinical areas. So from the point of entry into the organisation, and that guidance is not yet clear and not out. So what we don't want to do is to put visitors or patients in a position where the clarity isn't there, and we, as you know, on some occasions, some information comes out and then comes out and changed. We're anticipating more clarity on that towards the end of this week, but it's not in. We're also in a position where we are building up services again, and therefore, as we're doing that, we have got risk assessments we need to do, social distancing we need to be clear on, and ensuring that we've got stringent infection prevention control measures, and all of those things are a priority to keep our patients safe. We are absolutely understanding that part of safety is good communication. Therefore, a patient's relative or family are part of that care, and we get that. But we have other means at the minute where we can do that through iPads, through phones, through other conversations, which we need to do and do. But actually, the visiting element of it, whilst it's good from a mental health perspective, and understand that, I think our safety measures are the things that are paramount for everybody at the moment. That's the reason we haven't changed the decision. We are monitoring it and keeping an eye on it, and we've talked it through executive strategic COVID meeting, and we will again discuss it in Monday when the next meeting is. We are getting ourselves ready. Egypt is working on this call. I had a call with our managing director for DSFS, who supports the process of making sure the right PPE equipment is in place, and having a conversation with him about if we were to do X or Y, are we ready to take that step forward? So we're all ready. We just need to make it for our patients and staff.
Thank you very much. Then we've also got a request from Judy for an update on staff who've contracted COVID and how they are.
So from a sickness absence perspective, where staff who are off as a result of sickness absence shielding to do with COVID is at just under 5%, 4.94%, which is again a really good position. We've seen the number and the levels coming down. One of the initiatives we've taken is to have conversations with our staff around what they're feeling, how they are, and particularly those that are off sick or our BME colleagues as well. And so there's a real clarity around the support that's given into those staff and the offer that's there that's already been mentioned by Zoe. So we've got more staff back than we've had before. Again, a little bit of a word of a caution, because as social distancing relaxes, as more organisations are going back to work, there'll be partners of staff going back to their work that may well be more exposed than they were before. So it's all part of the monitoring of the situation, but that's been, you know, it's a good position to be in at the moment. That is helping us, although we've still got staff that are off from COVID at the minute. Hopefully that covers an answer for that.
Thank you very much, Lynn. Frank, I just want to check, is your hand up from the last time, or did you want to come in again? It's down now. Okay, I'll take it that that was just up from before. Very good, and thank you for that feedback on that question, Glenys. So I think we've probably done justice to the Chief Exec's briefing. It's been very comprehensive. I mean, I just have to reiterate huge thanks to all our executive colleagues and to every member staff in the Trust. A particular thanks to Lynn and Tony, who have so visibly led the charge, but that for a moment doesn't overlook the fact that this has been a complete team effort, with, you know, Hal on the medical side, Zoe on the people side, and, you know, even the finances have flowed precisely where they've needed to flow at the right time. So thanks to Lee too. I get the team effort, but the intensity, I think, of some of the actions you've all had to deal with, not least of all manning the control room, and you know, that expectation you've put on yourself and created in others that you will be the visible face of leading this, has been fabulous, as indeed has the way in which you've created fellowship. I think one of the things I will reflect on at the end of this period is the fact that one of our COVID wards was staffed entirely by volunteers. And I think, you know, the way we have reached out to colleagues and they have reciprocated speaks volumes. And we always say that Chesterfield is a lovely place to work and it's a lovely place to be treated. But there's a real test, isn't there, of your resolve and your ways of working at a time like this when there's such pressure on everybody, and the extent to which colleagues have supported each other is to be hugely applauded. But of course requires the sort of style and tone of leadership we've had from our executive colleagues over this period of time. So you've been magnificent, each and every one of you, and we're hugely grateful. So thank you. I'm going to move us on, if I may, to the success method. So this is the paper we've got, which follows the particular areas where Council of Governors have said they are putting the non-executive directors on notice that they're going to be tracking progress very closely. And in what has now become a time-honoured tradition, we're going to go around the table and we're going to get the update from the lead non-executive director for the particular areas. So if I could go to you, Jane, in the first instance, please, to talk about patient care.
Thank you, Helen, and good afternoon, everybody. So I think you've got a report in front of you. What I'd like to do is just pick out some of the highlights of the report, but I just want to make it clear that this report is a look back over the priority area for the whole year, so looking at what's been achieved through Quality Assurance Committee, but also has some current information just to assure people about the impact of COVID and the way that Quality Assurance Committee in particular is continuing to work. So I can say that we believe that we have significant assurance against this priority, which relates to delivering an outstanding experience of care for our patients, and also particularly also recognising great care. So the first thing that I would like to point out to you is under leadership, capability and capacity. I just wanted to say that Quality Assurance Committee is one of the committees that has continued to work as normal during the COVID pandemic, and that will continue to be the case, and that's part of a national directive. Some things have been paused, and Quality Assurance Committee again received information on that. And a particular interest to the governors, I think, will be the fact that the quality account is likely to be delayed until December. Now, we're in a great position on this already, in that we've already circulated our draft, but we clearly wait to see whether there's further guidance that's going to come out on the quality account later in the year. So that was just to assure you around the quality account. That's not missing. It will appear, but according to a national timetable that's rescheduled. I also just wanted to point out, with thanks to Helen for recognition about the work on ethical decision making, the Quality Assurance Committee has held an extra meeting during the last quarter when we looked specifically at ethical decision making, not only for our COVID patients, but for all the patients in the trust. So making sure that we were doing the right thing for all our patients, and we were following national guidance. In terms of vision and strategy, I wanted to commend the progress against care accreditation assessments, particularly because that's also been recognised by CQC in their report as a really robust mechanism, and also the progress that's been made in ownership of family and friends and family test targets by the different care units. In terms of governance and management, I've identified for you there the different methods of information that comes to me as chair of the Quality Assurance Committee, the whole committee, but also different things that the non-executive directors that are members of the committee also get involved in. And clearly there's also thanks there to our governors who are now providing the ward reports to the committee. There's also information to suggest that we have had external review by 360 Assurance showing that the working of the committee is in fact robust. In terms of management of risk and performance, you'll know that we look at all of our quality indicators and the performance report on a regular basis. And particularly this year, we've been looking at pressure ulcers, falls and the Clostridium difficile targets, and all of those have received our particular attention. Really pleasing to note the progress that was made against the falls sequin, and also to note that the falls specialist continues to be in post, and that really is really important for us as we take that work forward next year. In terms of friends and family test reporting, we've had some anxieties about levels of achievement of friends and family, sometimes about the number of reports that we're getting, but sometimes about actually the sort of overall levels. What I wanted to say was actually we've got some really good progress in Royal Primary Care, and this is a really great achievement now, showing that we are above the trust target and above the national average in terms of patients recommending Royal Primary Care. So again, I know governors are really interested in what happens in Royal Primary Care. In terms of actions that we've been following related to CQC, again, really pleased to report that the breach notice against Mental Capacity Act and Respect doesn't appear further in the new report. There is a related topic around deprivation of liberty, but I think we have made absolutely great strides in terms of mental capacity and respect, and I know that we'll be focusing on deprivation of liberty going forward. The other area I know that is of concern to both the board and Council of Governors is infection control, and again I can assure you that we'll be continuing to focus on that as we go into the next year. In terms of one of the things that was a real key objective for us for this year, we really wanted to strengthen our assurances on clinical effectiveness. And whilst I think we've made good progress on this, I think there's still quite a lot of work to be done. And again, I think that's clear from the CQC report that we do need to continue to have a real focus on that. Very pleasing though, we've moved really quickly now to put in place the hyperacute stroke unit, which again is the result of our examination of our mortality around stroke. Some great information now coming to us on staffing, using the safe staffing system. That's in its infancy for us at the moment, but it is proving to be really helpful. And again, the performance report is now in a different format, and that's helping us to focus on the right things using statistical process. In terms of learning, improvement and innovation, we're always delighted to hear what's new and where we're moving forward and where we're a bit of a leader in things. And actually, again, just wanted to point out again from the CQC report, we've been using the swarm process to review pressure ulcers, and actually that was commended again in the CQC report as a really robust process. As I say, we want to really focus on innovation and good practice, and in terms of using methodologies to bring together our focus, we're really pleased that we're now moving forward with the QSO methodology, which I'm sure one of my colleagues will talk about in more detail later. I wanted, with your permission, Helen, just to ask Lynn if she just wanted to make a comment on the CQC report.
Thank you very much.
The reason being that the report is not yet in the public domain. Well, sorry, it is in the public domain, but it hasn't been considered by board. And clearly, we also haven't had time to consider it through Quality Assurance Committee in terms of the action plan. So, with your permission, if I can just pass over to Lynn to finish off.
Thank you, Jean. And as board members will recall, the report came in as board finished, so we didn't have the opportunity to and it will be going to board in due course. The points I wanted to raise were obviously some very good examples within the report from urgent care, medicine and surgery. And there'll be some nuances in there that you might look at that you think that's a bit strange. For example, the Macmillan unit is sitting in surgery, but that's how the CQC look at the core services and the measures and how they put them in place. But with regard to the rating, which is my specific points, we didn't have the well-led element of the inspection because of COVID. That was suspended. They are unlikely to come back and do that, given the conversations that I've had with them now, because they're moving into a risk-based approach assessments moving forward in this year, given the circumstances, because they also have staff that have gone to work within clinical areas. So they're taking a different slant just slightly for this year, although they obviously still have their usual inspection regimes. So we missed an opportunity to make sure that the well-led interviews took place with executive and senior colleagues to add further substance to the quality of the information that they received. Therefore, in terms of the rating, those of you who have had the opportunity to look at the report will notice that we have maintained the good overall as an organisation, and that in medicine care, including older people's care, that effective domain has gone from good to requires improvement. And the areas that are of note within that, Jane's already pointed out, to do with clinical effectiveness, to do with elements to do around decision making, etc. So there are points that we're already focusing on and taking forward, and that fit into the must-dos and why that has changed that overall rating for that core service, and therefore the organisation stays totally as good, because mental health services added in as well. It's quite a confusing way of looking at things, and CQC don't make it easy for us, but I just wanted to make that point clear, that overall we are good because we bring the services of the trust, hospital side and the mental health services together to give us that process.
It may be a complex picture, but we're not all at all confused, Lynn, because we're delighted and completely understand that we maintain our good rating. So well done again on that. That was a lot you've gone through, very comprehensive report, Jane, and we're very grateful to you for it. And I'm sure colleagues may well have questions, but I'm just going to go through the report if I may. So if anybody's got questions, just hold on to them and we'll come back. So if I can go to Sue next, please, to give us the update on the Improvement Academy and change capability priority that we have.
Thank you, Helen. Can you hear me okay?
We can hear you perfectly.
Good, thank you. I'm carry on, assume you can hear me okay. So thank you Good afternoon. Proposing to read through the report because hopefully it's all very self-explanatory. I think from my perspective, what I would say in terms of feeling assurance about this particular strategic objective is that I think the approach that's taken in the Trust for creating the ability for change and for staff to get involved is incredibly well done. It's very thorough, it's very professional compared to what I see in other organisations. The governance around it and the kind of the project management office, the PMO approach is really sound. I think what's been particularly interesting in this last period really is that if there's ever been a time for this capability that has been grown and built and developed in the Trust to come into its own, it has been now really. So I think as you might have seen, if you've read onto the preparation for winter and the learning from COVID, what we've seen really in the response to this is that a number of our existing improvement plans that were, you know, as ever with any project plan, we're planning to be over months or even years, they've been fast tracked astonishingly in weeks. And as you've already heard us talk about, in particular, things like the new pathways for patients and virtual outpatients. And I don't think it would have been possible for us to respond to that in the way that we have without the high engagement approach that's been going on, but has been particularly dialed up really during this time to enable the Royal Academy of Improvement teams and the operational staff and the clinicians to work together to really be able to make things happen quickly, the fast decision making that's gone on for us to be able to respond in the excellent way that we've already heard us talk about. We have talked about this at board because it's true to say that, you know, only a crisis actually really produces real change, which is a fairly existential comment, but is true. And I think what we now, going forward for this strategic objective, are very minded about is how do we keep hold of that ability to accelerate change where we think it's necessary, and really learn from what we've learned in this time in terms of really maximising the benefit of that staff engagement. What the Royal Academy has done, as is described in the report, is build capability in with 85 practitioners now who are able to apply this improvement methodology, and so we've boosted that capacity. So it's how do we then grow that, but really make that capability come to life with the changes that we know we now know we can make happen, and we can make happen quick even in the NHS. So I think it will have been very empowering for staff, and I'm looking forward to us having a chance to get that feedback as we go forward. I don't want to steal Zoe's thunder, wish there is an agenda item on our staff survey, but I think when you look at that and the staff engagement scores that we've improved upon, and the way that we're closing the gap in the highest point on staff engagement is also testament to that. So I don't want to say much more now, except to say that I think through the work that Tony and Maria have been leading through the Royal Academy, and the way that that's been pulled together with the operational and strategic activity that we've needed to do in response to COVID and looking ahead, I think has been a phenomenal success, and I'm looking forward to seeing that grow as we go into the next year. I think we've really built the capability, we've proved it can work, and I think with every confidence now in going forward that we'll only grow from strength to strength in that. So just to say thank you to all the team and everything that's been done, and I think that council and board can feel very assured that we're in a very good place to build on this in the year ahead. That was all from me, Helen. I think the report's pretty self-explanatory, hopefully, but happy to take any questions.
Thank you very much, Sue. I'm going to go to Keith. You might need to go on mute, Sue.
I think Keith's not with us, Helen.
Oh, is Keith not with us? Okay. In which case, I'm going to go straight to Jeremy and put Beverly on notice that we'll come back to you for the RPC update, please, Beverly.
Oh, sorry, okay.
Okay. So, Jeremy, please.
Thank you, Helen.
I don't have much to add to what's written down in the report here. The timing of people committee meetings has not really gelled very well with the timing of COG meetings. Our last proper meeting was actually on the same day as COG on the 5th of February, and that was the last occasion on which we formally considered the assurance of this priority. We did have an additional meeting right at the beginning of the lockdown period on the 8th of April, but it was a very pared down meeting. I think we were really still trying to find our feet in terms of how to handle assurance committee meetings at the beginning of the lockdown period. I think the two things to highlight, firstly, in terms of the work done, firstly, the work done by Zoe and team in supporting staff through this period, and you've heard from her already during the course of the Chief Exec report update. And then, of course, the staff survey results, which are very, very encouraging, which have come out since I last reported back to COG on this. And there is a separate paper, obviously, on the staff survey, so perhaps we can go into a bit more detail about that then. Otherwise, I'm very happy to take any questions later on what's in the written report.
Thank you, Jeremy, for that update. Atul, if we might go to you for innovative service delivery models and the place structure, please.
Thank you, Helen, and good afternoon, everyone. Well, of course, the COVID experience has been a hotbed of innovative ways of working, and particularly at a system level. And as you've heard earlier from other executive colleagues and from Sue about the Improvement Academy, the challenge has been to capture these innovations into, and I think, the new NHS going forward. So there's a transformation phase also being put in place in addition to restoration and recovery. And in this transformation phase, particularly, we need to capture all of this innovative best practice that's going around. We had a bit of a discussion at the last board meeting where we've asked Tony to just compile a simple list of all the new ways of working that have benefited patients and reduced bureaucracy, and give us a whole load of real examples of that. And of course, in terms of the future CQC inspections, not just the one we've had, but we're going to have, we will have another inspection in a year or so's time, that we need to demonstrate how we've embedded these innovations and demonstrate the golden thread that inspectors are looking for in outstanding organisations. So all in all, a very fertile field, lots of innovation going around and being embraced. The challenge is to capture all of that, embed it and follow it through.
Thank you very much, Atul. Have we got Mike on the line, please, for procurement?
Yep, I'm here. Hello, everybody.
Hello, Mike.
When we were last together on this subject in the COG in the hospital, Lee mentioned this 3-stage accreditation process for procurement standards in the NHS. And as you can see from the report, we've now been accredited with the first of those stages. So that's good news. We've moved the efficiency and the effectiveness of the department on considerably. The next 2 stages are very hard to come by. I've been doing quite a lot of digging while I've been off, like everybody else has, I guess. And the level 2 accreditation isn't just focused on the department itself, it's focused on the entire hospital. And the level 3 accreditation is the hospital interacting into the wider community, as things like centres of excellence and training courses and all sorts of things. So our strategic objective of getting level 1 in the first quarter is sort of a little bit late by COVID, but it's been achieved. We have a strategic objective to get level 2, or to start preparing for level 2, in the 4th quarter of this year, which we are ongoing. And as you know, I come at this kind of problem from 2 angles. One, I have this NED responsibility with you guys in the governance, but I also have the mentorship, for the want of a better phrase, of Dennis at the SFS. Not that Dennis particularly needs a mentor, but I kind of chair the oversight committee. Dennis and I speak, or have been speaking, every week throughout the COVID crisis, and most of our conversations have been on the PPE kind of procurement issues and any other emergency issues that we've got. as those start to bottom out, and as you heard from Lynn, we've always got at least 3 days worth in supply. I can now spend a little bit more time with Dennis on a roadmap, as we've put in that report, for the final quarter, that says how we can start thinking about moving the organisation onto getting the accreditation for level 2. I need to be honest, it won't be easy. I've trawled through this documentation, and it's like a lot of NHS stuff. There's a huge amount of, there's about 8 or 9 pages of qualitative measures as well as a few quantitative measures that we have to achieve, and a lot of the accreditation will hinge on our e-procurement and our digital effectiveness, and I think we have a little bit to go in that area. But the good news is we've stabilised the department, we've got accreditation at level 1, and we are acutely aware of what needs to be done for level 2, and we will start making real progress towards that once we can get into the 4th quarter and a bit more freedom of meeting and a bit more focus on non-COVID items.
Very clear and helpful. Thank you, Mike. Alison, if we might turn now, please, to the IM&T strategy.
Thanks, Helen. So I'm going to assume that people have read the document and just add a couple of comments. As all areas of the hospital have been impacted by COVID, the execution of the IT strategy and IT facilities has been impacted. I think firstly we should recognise and congratulate Ian Hizeel on the great work that he's done in completely pivoting and implementing the new IT services that have been required through the COVID period to enable the hospital to move 1,500 staff to home working and to change our interaction model to virtual models for patients. So that's the positive side. The slightly negative side is we had signed off our IT strategy and we were merrily implementing that with the right level of investment. And although we were disappointed with the STP digital strategy, there was at least a plan in place. Unfortunately, that plan has been significantly disrupted by COVID, and progress on some of the assessing the software and hardware that's currently in place and then creating a cross-system roadmap of where we want to go has proved to be very slow during the COVID period. So the hospital is still functioning. Ian's doing a great job. Some of the wider system stuff has been slowed, unfortunately. I'll let Helen manage questions further on.
Thank you very much, Alison. Beverly, might we come to you now, please, for the RPC update?
Yes, thank you, Helen. Just to give a little colour to the report that you have on RPC, like other areas of the Trust, the COVID challenges have really led to some serious opportunities, which hopefully we'll see continue post-COVID. Maybe just to put that into context, if we look in the early stages, the number of face-to-face patient consultancies in a week dropped from 338 to 15. Telephone conferences with patients increased from 49 to 224, and home visits dropped from 186 to 26. So it really is just a massive and instantaneous change to the way we service patients, which the team at RPS have responded incredibly well. The report mentions recruitment, and again, an advantage from COVID. The feedback is that the locums are not finding it as easy to get work, so they're now actually approaching us looking for vacancies. So there is some optimism that the 3 GP vacancies will be filled relatively easily. So we hope that does come to fruition. Ashgate, the merger has gone well, and again, due to COVID, there's been staff shortages. So there was a natural merger of back office teams. So everybody's been forced into dealing with work in a different way, and that has generally been well accepted. We're fortunate to have incredibly strong leadership in RPC in Joe Lacey. Peter's unfortunately been on sick leave, and we're hoping he'll be back in July. But Joe has really, I think, on the issue of governance, she's built on her knowledge of processes in the Trust. Of course, she was very instrumental in writing most of those. And she streamlined those to reflect the skills and time availability of the staff in RPC. So reports are that that's all going well to plan. In terms of new ways of working, Joe has set up a daily conference call, which remarkably has 100 participants. And both administrators and clinicians, and they only last 10 minutes, but like any business, communications is key. And Joe has the opportunity to feedback on what national guidance might be in various areas relating to COVID. But also it gives the staff the opportunity, for example, if one area where GP is short, somebody else can move somebody across and slot them in. So that's just been a really efficient way of informing people in quite a small time slot. She's also set up a leadership cabinet, which meets for about an hour every week. That includes clinical needs and site nurses. And in the early stages, that was more about decommissioning services. And of course, now they're really focused on the reinstatement of services. And the message from the team is very much, they want to keep their innovative ways of working. They're feeling empowered in the way they've been involved in decision making. And they really don't want to go back to the old way of working, which is great to hear. The GPs are all equipped now with laptops and equipment. They can issue prescriptions remotely. Obviously, video conferencing is in place for patients, which not only gives us flexibility, but in terms of business continuity, if ever we do face another challenge, we're much more geared up to deal with it. In terms of streamlining services between the Trust and RPC, the feeling is very much that this has to be a PCN approach. I know there's still much work to do in building those relationships, but we've already moved to ultrasound in RPC, and there's talks around diabetes, rheumatology, other areas. So the management team at RPC and the clinicians are obviously very proactively engaged, which is very positive feedback.
Tour de force, Beverly, thank you. I hope nobody's going to find the comments I make indulgent, but I really feel moved to make them in the same way that I thanked executive colleagues for their work on COVID. I really feel the need to actually echo some comments Denise made at the end of the last board meeting. I think those reports on our key priority areas from our non-executive director colleagues have been magnificent. And to coin Denise's phrase, really show the extent to which NEDs, despite the constraints of remote working, have kept not only on top of their brief, but as Beverly has so ably demonstrated in that last report on RPC, which is not her brief, but obviously part of our collective responsibility as NEDs, the extent to which we've been able to keep abreast of things across the Trust. As I say, I wouldn't wish to appear that I was making indulgent comments of my non-exec director colleagues, but I really do think the calibre of those reports need to be appreciated. So thank you from me. We've got a question already from Luke, and I'm going to go to Luke in the first instance.
Hello, it wasn't necessarily a question, but just a point following from Alison's update, just in the fact that I'm aware some people might be concerned that the IT implementation might have slowed down during COVID, but actually I'm wondering whether it's almost seen as a positive, because what we implemented before COVID might not have been suitable for the new ways of working. So I guess that's just a consideration, almost a positive spin on it, that actually now we might want something very different to what we previously thought.
Helen, do you want me to answer that one?
Please.
Thanks, Luke. I think it's a really interesting point, and I think the speed at which Ian and his team have been able to pivot the hospital operation and technology enablement has just been phenomenal, absolutely phenomenal. And is an exemplar of what the hospital can do. I think we've talked previously, my assessment and also Keith's assessment, that the STP digital strategy we didn't think was fit for purpose. So I think the hospital has done a great job. I think it is a opportunity for the STP to reconsider what it thinks appropriate solutions might look like. So there are positives in the negative.
Can I check, would anybody else like to come in with a question or comment on any of the reports on our priority areas and our success criteria? Okay, well, I think the comprehensiveness of the report has probably been demonstrated perhaps in the lack of questions. Now, we are due to have a short comfort break. So,
sorry, Helen, if
yes.
I may interrupt. There's the other part to the recommendation there as well, which was about thinking about the priorities for 2021.
Absolutely. Thank you, John, for the reminder. Do you want to just say a word about how we're suggesting they're brought together?
Well, really, one of the ideas of bringing it here, and I think one of the appendices to the report shows some of the trust priorities picked out in March board. So really, was there anything that governors wanted to pick out for us to focus on next year, well, this year now, or if more helpful, we could perhaps do it as a kind of a paper exercise, an email exercise outside of this meeting, if we don't want to do it now.
Yeah, I was going to suggest that unless somebody's got really something pressing to say, it's going to be hard to do it in this format, because if you recall last year we had a really interactive session with all sorts of bits of paper and what have you to kind of whittle down and focus our areas of priority. And I think it's really important that we don't, and I see Denise agreeing with you, I think it's really important that we don't rush this, because you know what gets measured, what gets measured gets managed, and you can see the importance and seriousness with which NEDs take driving through governor priorities through our board meeting and beyond. So in the absence of immediate comments, we might think about how we do it, perhaps taking something through nominations and also the outreach committee. In the absence of being able to have a more interactive session, and then we could bring back a proposal perhaps to the next Council of Governors meeting for you know, it be easier to ratify, I think, in the full group. So can I just check if anybody's a burning comment they want to make on that? No, it looks like there's some agreement to that being a sensible way forward. In which case, but thank you for the reminder, John. In which case I am going to release you to your comfort break.
Helen, sorry to interrupt. Tony will have to go at 3, not wanting to delay comfort break. Do you want him to introduce the R&R? I'm happy to pick up the questions and details, but I don't want to take credit from Tony, who's done all the work.
Yes, thank you very much for that reminder, Angie. If folk can bear with us for a little bit, let's take up Angie's suggestion and go now to the to item 8, yes, which is the R&R, restoration and recovery, as not rest and relaxation, I hate to say, so to add, post-COVID. So if you'd be kind enough to introduce this, Tony, and obviously stay for as many comments and questions as you've time to accommodate, but then if you need to go, we'll take up Angie's kind offer to conclude.
Thank you, Helen. Thank you, Angie. It's actually been really fascinating listening to all the reports that have come through right from the start of the meeting, because they all triangulate beautifully with the transformation agenda and with the restoration and recovery. The report, I'll just give you an overview. The report lays out certainly the lessons that we learned from the winter period, and I love the example of Elizabeth because of many lessons we learned on the Women's Health Unit, which we only reviewed at board last week, and we've had it at other forums. Elizabeth was the complete and utter opposite, as you rightly say. Volunteers, they came together as a team brilliantly. We gave them the freedom to act and engage and modernise and change the way we do things. And when we stood that ward down as part of the de-escalation, they were so sad as a team to break up and step away from what they called the front line, because they're very proud of the fact that they were first up in terms of a COVID ward, and all credit to them. But the feedback from that demonstrates the lessons learned. But whilst we're very, very watchful of our COVID situation, as Lynn has already alluded, it's starting to ease, but we're very watchful of a wave 2 as some of the distancing elements get relaxed. Simon Stevens had put a note out, late April to sort of start to think about restoring and recovering essential services. It's not the full Monty in terms of all of our services. It's essential, urgent work. And it goes in phases of 6 weeks at a time. So at the point we were quite early putting this report together. So you've got an early version of the restoration and recovery plans, I think from about mid-May. The colour coding, if it's green, it means we're on track and we've done it, what we said we would. And if it's red, it means we're not quite ready. Just to give you the assurance, this is the 6th week of that plan. So we're progressively building up the next version of 6 weeks, which I review every day from 12:30 to 1:30 from an operational point of view. And tomorrow and Friday, we'll be confirming the next wave of 6 weeks. We'll be taking it to our strategic group on Monday, so they've got complete oversight of that restoration plan. And then we'll take that forward. What I would, just to help you, when you look at the back, when you look at that matrix and the colour coding, it is not a simple task standing services back up when you take into account all the social isolation, the distance in the PP, the testing, the safety of bringing someone on site. Have we got the capacity to deliver in terms of the procedures? So we're using even off-site facilities like our independent sector and some of our community settings. And that great example that Beverly gave of Royal Primary Care, they're linking in with the acute as to how they can support the restoration as well, which is excellent. So I'd like to provide councillors with the assurance that we review this programme daily. You are looking at a very much out-of-date version of the plans. They're reviewed. We go through the governance of tactical and strategic as appropriate. The team are working fantastically well together, and I mean that right across the trust. And as we've already said, the Improvement Academy are right in the mix of this, embedding the changes that we've seen come through the height of COVID and looking to hold on to them. So Helen, I'll draw breath at that point and take any questions as best I can whilst I'm here.
Thank you very much, Tony. And of course, that was item 13, not 8, Australia's restoration and recovery post-COVID, and a very comprehensive update. And again, being able to keep this balance between dealing with the immediate and getting ready for the future is also a testable, well-led organisation. So further applause and appreciation in that regard, Tony. Can I ask if anybody would like to ask Tony anything or share any thoughts with Tony about the restoration and recovery programme? Yes, Greg, if you'd like to come in.
Hi, thank you very much, Chair. Tony, can I just confirm, as well as working closely with Royal Primary Care, you are also working, I know you've had meetings with Ruth Cooper, but you're also working, bearing in mind, North East Derbyshire GP practices that aren't involved in Royal Primary Care?
Absolutely. Only last week, I think Maria was presenting to the whole group of GPs talking about the changes we've introduced and how we need them to work with us and us to work with them to make sure that the patient pathway is as smooth as it can be. So absolutely.
Thank you, Tony.
Very good. Anybody else like to come in on this, or are you content to note the report? Well, there's a few well done, Tony's great plan, and we've now got 4 likes. So I think that means that you are released onto your next meeting, Tony. But thank you very much for being here so far. It also works out really well in terms of taking a comfort break, because it's precisely 14:50, which means if we could all be back at precisely 1500 hours, we'd have precisely 10 minutes. So my strong advice to you all is not to dial out, just go on mute, cut off your video if you want, maintain the connection and then boil your kettles or stretch your legs, whatever you'd like to do. But we'll start again promptly at 3. Thank you very much. item 15. The date of the next meeting is the 22nd of July. And we're just going to have a review of the meeting, not least of all in the interest, please, of us being able to further refine the format for the 22nd of July meeting. Can I go to you, Denise, in the first instance, please?
I think it's worked well. I think the quality's been really good in terms of the sound quality. It was a lot better than when I listened to the board the last time. I think it makes it better because we can see people. So I think that adds, and I think it's gone really well.
Thank you very much, Denise. Thank you. I'm also conscious that there are probably a number of items that people under the normal course of events would have, you know, made a comment on, but probably have been very mindful in the interest of the kind of virtual dynamic to keep the powder dry, unless it was a very significant or material item. And I suppose to just record thanks to colleagues around the table for, in that regard, making the meeting very manageable. And we might in that vein reflect on maybe having some more consent items, ones where, you know, we won't pause to take questions on them if we don't anticipate there will be, but we'll give people the opportunity to flag up in advance if it's a particular item they'd like to discuss. And we've been doing that for board, and it's actually worked really well. So we might think about how it is we could extend that to council to governor meetings. Can I ask, are there any more feedback? Thank you for Glenys, splendid meeting, excellent reports, easy to understand information. So thank you very much, Glenys. Anybody else like to comment? No, in which case I'm just going to do a final check with Gillian if we've had any questions from members of the public. No, the answer to that is no. So thank you all very much. I know that it takes a lot of attention and energy in this kind of two-dimensional world, particularly for meetings that go on for a few hours. But your attentions have been of their usual fine quality, and we're very grateful to you. And stay safe.
Ellen, can I just say something before we leave?
Please.
I can't let Lynn go without from the governors saying that how much we're going to miss her. We think she's done a fantastic job, not just with the COVID. I mean, I think she's been outstanding during the COVID, and particularly keeping us up to date. Her reports have been excellent. We've really felt involved, and I think that's down to obviously Lynn working with the team, but Lynn leading it. But for her work before that, her work with the CQC about improving patient staffing and all the work she's done. So we'd just like to say thank you very much, Lynn.
You're a star, Lynn. Very well done. And I keep reminding you, you're having a career break, not a retirement. So enjoy it while it lasts. But thank you very much, Denise, for those kind words as well on behalf of the Council of Governors. So with that, I shall release you on to what's left of your afternoons. Very many thanks.
Thank you, Helen.
Yeah, bye.
Bye. Thank you.
Goodbye.
Bye.
Bye.
Bye. Helen, are you still there?
I am.
Yes. Now we're officially off. It's a humorous one. I think we should have a competition to decide